Mr. Prime, some of your PMAMT. Plans are introduction, methodology, literature review findings, qualitative interview findings, discussion, and references. Introduction. Patient-centered care is a model that actively engages patients in decisions and tellers. Services to individual patients' preference, needs, and value. This approach contrasts with traditional reviews focused on physician-driven modes of healthcare service. The Institute of Medicine identified PCC as one of six vital domains required to improve healthcare quality in its one, crossing the quality charms record. PCC requires rethinking relationship among patients, families, and more participatory, collaborative, and empowering for patients. Core principles and practice underpinning PCC include fostering partnership between patients, families, and providers, offering coordinated and customized care, providing clear communication of options that respect physical comfort within healthcare environments, and supporting patients to manage their own health. Critical dimensions of PCC encompass information sharing, patient empowerment, support coordination, and transition, physical comfort, emotional and psychosocial support, family and friend involvement, and approach to service. Next is methodology. This study utilizes a mixed method approach to evaluate the impact of patient-centered care models on hospital operations and quality. Structured literature review provides great on documented PCC outcome across published studies. Semi-structured interview with hospital administrators immersed in PCC transformation then offer in-depth qualitative insights into the complex clinical, technological, and cultural changes required organization-wide. The multifaceted methodological integration paints a robust picture of PCC adoption considerations of hospitals leaders. the literature review offers starting insights into PCC's impact but could not capture subtle leadership, change management, and adoption nuance in hospitals transformation. The supplementary semi-structured key informant interview with hospital administrators and clinical directors provide qualitative data on the ground of converting to PCC's models. The research team recruited 15 participants across nursing, medicines, and administration at different large hospitals, nationally recognized as leaders in PCC delivery based on public quality ranking or awards. Hospitals were purposefully sampled for diversity of geographic region, urban, rural settings, academic or community status, and patient population served. Potential participants were identified via hospital website and public mention of PCC initiative. Recruitment email explained the study purpose and 60-minute interview commitment required. The first 15 administrator or clinical leaders agreeing comprised the final sample. This adequate qualitative sample size enabled capturing a range of multifaceted perspectives until the thematic saturation occurred, whereby new interview produced minimal additional themes. Things Literature findings. The structured literature sourced on hospital-wide patient-centered care impacts yielded 2,468 unduplicated articles with 51 selected for full text and review based on title or abstract screening against eligibility criteria. Just 23 studies made all inclusion factors for rigorous PCC evaluation designs and hospital level outcome measurement. These encompass three Twice experimental studies, 10 pre-post design studies without control group, 5 observational cross-sectional studies, and 5 qualitative case studies. Represented hospitals spanned academic medical centers 9, large community hospitals 8, and smaller rural hospitals 6. Key PCC elements assessed across studies included patient or family advisory councils besides clinical handouts, open medical record access, patient education enhancement, and transition programs. As shown in Table 1, investigated outcomes metric cover clinical quality and safety indicators. There are 16 hour studies regarding this patient satisfaction and experience survey. There is 14 hour study and operational workflow measures. There are 7 hour studies and staff perception and engagement. There are 5 hour studies and direct financial costs are saving. There is 3 hour studies. The most consistent positive PCC effect observed across setting were reduced hospital readmission rates. 8 out of 9 assessing studies shows that, and improved patient satisfaction score. 12 of 14 studies shows that. For example, the hospital implementing patient advisory counseling and enhanced discharge coordination saw 0.8 days average shutter stay, 10-point better experience score raise, and 14% drop in 30 days return versus just 0.2 days shutter stay, and 6-point better experience rise in the control. Mixed operational impacts emerged with 4 studies, nothing increased direct care time demands, but patient portal uses and medication scan data suggestions better self-management engagement outside visits. This aligns with modest PCC cost increases seen in 3 economic studies for added patient education material and staff training investments. Interestingly, the 2 studies analyzing staffing with PCC found decreased nursing turnover on redesigned units. Overall, PCC shows positive quality results but requires leadership support navigating workflow adaptation. The quantitative impacts. The 15 key informant interviews provided these insights into the participant structures, implementation process, and leadership support perceived as vital to successfully improving hospital PCC. All participants described multifaceted stepwise rollouts, beginning with securing aligned executive commitment before engaging unit-based improvement teams in need assessment, intervention, planning, and launch. Most started small with pilot flows before spread. 3 overarching thematic categories emerged, explaining essential PCC adoption steps alongside illustrative codes. The quantitative survey findings are implement the literature and interview data with systemic input from a wider population and anonymous online survey, collected perception of patient-centered care delivery changes from 322 frontline nursing and clinical staff across participating hospital after at least 1 year of PCC model implementation. The survey consists of 5 points Likert scale questioning gauging the frequency of specific patient-centered behaviors and practices observed by a respondent in their units since PCC enhancement, with higher score indicating more frequent PCC behaviors. 8 key PCC delivery subdomains were measured, including care personalization, patient education, family inclusion, collaboration with other specialties, shared decision-making, care continuity, emotional support, and physical comfort. Next, come to discussion. This mixed method study generated multifaceted insights into the operational impacts, key implementation facilitators, and major benefits of converting hospital to more patient-centered care models. From integration with prior literature, the qualitative findings emphasizing hands-on leadership, commitment to propel organizations culture changes, substances conclusion from prior systemic review, flagging lack of GSUIT support as a common PCC barrier. Notably, no knowledge synthesis studies or commentaries previously detailed The types of clinical tools enhancement. The practical implementation implications as hospital system pursues increasingly aggressive quality-based incentives and regulation tied to patient-centeredness principles from bodies ranging from the Joint Commission to Medicare. This study provides realistic guidance for administrator planning PCC transformation. For instance, a hospital launching a patient portal and tablet system for bedside education and transparent EHR access could estimate cost using ballpark figure here around $5 million annually. The research, the scope of research, follow inquiries should expand application of mixed method assessments across hospitals in earlier PCC adoption phases to detail how business case projection, pilot selection, and incremental plans unfold. As participating future research follow-up inquiries should expand application of mixed method assessment across hospitals in earlier PCC adoption phase to detail how business case projection, pilot selection, and incremental plans unfold. As participating institutions progress to mature sustained PCC delivery longer outcome measurement will clarify true cost and satisfying efficiency over time. Is this mixed methods study integrated literature evidence qualitative insights from hospitals, administrators, and nursing staff survey data to evaluate the organizational changes implications of adopting widespread patient-centered care models. Multiple findings confirm existing evidence. Developing the business case for resources around spaces, technologies, training, and governance to allow patient personalization, access, and navigation voice at all levels emerge as achievable. Successful hospitals and PCC philosophies through consistent middle manager support, empowering frontline care with designs as well as leadership role modeling the value during rounds. They also progress systematic stages ensuring patient portal compliance, transparent data sharing, family accommodation policies, and advisory forums enabling participation in decision at scale. These are the reference from where I did the literature review.